Hello and welcome back to a new video. So here we will talk about the treatment of hernia. So hernia is treated with surgery, and here we will talk about on which type of hernia will require to be repaired as soon as possible and which doesn't. And we also will talk about the details of the surgical treatment of hernia. You can always skip to other parts of this video using the video chapters available in the video description. And first, let's start by talking about the principle of hernia treatment. So hernia is treated with surgical repair. As I mentioned, there is no conservative therapy for hernia, and reducible abdominal wall hernias doesn't necessarily require repair. So reducible means that the hernia content can be pushed back into the abdomen. And this type of hernia doesn't necessarily require to be repaired unless the patient requests the repair for symptomatic relief, like maybe the patient feeling pressure at the area of the hernia, or they feeling pain, and that's when they request the repair, or for cosmetic reasons. And the surgeon might request a repair to establish the diagnosis if in doubt. So if the diagnosis is not confirmed yet, even with the investigations that can be done, then the hernial repair is used to establish the diagnosis. Irreducible abdominal wall hernias always require repair. So irreducible means that the hernial contents cannot be pushed back into the abdomen. And this type of hernia always requires the repair, because if not repaired, then complications are likely to occur. For example, bowel obstruction, strangulation, and infarction. These complications occur because of the abdominal wall muscles are pushing against the hernial neck, and this leads to bowel obstruction. It also leads to strangulation of the hernial contents and infarction. And that's why this type of hernia, the reducible hernia, has to be repaired. And if the patient tolerance for surgery on anesthesia is in doubt due to morbidity, then irreducible hernia surgery is done only if benefits outweigh the risks. So if the patient have other diseases that make the surgery on anesthesia risky for them, then the surgery is done only if the benefits outweigh the risks. And all cases of femoral hernias should be repaired because of high risk of strangulation associated with this type of hernia. So femoral hernia has a narrow neck, and that is why it has to be repaired, because there is a high risk of strangulation. And femoral hernia is located here. Also, reducible hernia with increasing difficulty in reduction and increasing size are also indications of surgery. So if the hernia is getting bigger, or if reduction becomes harder, then this is also an indication of surgery. And smaller hernias can be more dangerous than larger ones due to higher risk of strangulation. And femoral hernia is an example of that. Now let's talk about the surgical approach to hernia. So all hernias are treated through following these steps. Step number 1 is reduction of hernia contents into the abdominal cavity with debridement and bowel repair if necessary. So simply, the first step is that you push the hernial contents back into the abdomen with debridement of dead tissues, meaning the dead tissues has to be cleared, and the dead bowel also has to be cleared, and anastomosis of the bowel ends should be done. And then excision and closure of peritoneal sac, if present, and reducing it back deep to the muscles. So after you reduce the hernial contents back into the abdomen, now you excise the peritoneal sac and reduce it back into the abdomen too. And if the peritoneal sac is left without it being reduced, there is a risk of fluid formation within the sac, which is called seroma. And after you reduce the contents and the sac, then you close the abdominal wall defect. But this might be impossible if the defect is large, and that is when muscle flaps comes into play. So it is used to close large defects. And the defect can be closed with sutures alone, but this method is associated with high recurrence rates, meaning the hernia would reoccur at the same location if sutures are used alone, and additional reinforcement of the defect with non-absorbable mesh is better. So non-absorbable means the body can't absorb the mesh, and the mesh is used to cover the abdominal wall defect, so this would lower the recurrence rates of the hernia, meaning the hernia would not reoccur as much as with sutures alone. Now let's talk about the mesh that is used in hernia. So it's a prosthetic material. It can be a net or it can be a flat sheet. This is how it looks like. It's used to strengthen the abdominal wall defect, so the abdominal organs and fatty tissues cannot protrude through the defect again. So it lowers the hernia recurrence, as I mentioned. The mesh on two types. There is synthetic mesh and there is biological mesh. Synthetic mesh is the most commonly used type. It is synthesized from polypropylene, polyester, or BTFE materials. It is most of them are non-absorbable, meaning the body can't absorb them, but there is some that are absorbable but rarely used. And the other type is biological mesh. It is derived from human or animal dermis, bovine pericardium, or porcine intestinal mucosa. And this type is quite expensive. So both of these types, the synthetic and biological mesh, are expensive, but the biological is much more expensive than the synthetic ones. Finally, let's talk about the positioning of the mesh when it is used to repair the abdominal wall defect. So the mesh should be placed on a firm and well-vascularized bed. So well-vascularized to prevent infection, with good overlap with the defect. Good overlap means to prevent recurrence. And mesh could be placed on lay or inlay or sublay. Onlay is just outside the muscle in the subcutaneous space, meaning it's more superficial, near the skin. Inlay, it is within the muscle with the defect in it. And sublay is deep, and it could be extraperitoneal or intraperitoneal. Extraperitoneal is immediately under the muscle, and intraperitoneal is inside the peritoneal cavity. And this drawing explains the positioning of the mesh. So sublay is deep to the abdominal wall defect. So this is the abdominal wall, and this is the defect in the abdominal wall. So sublay, the mesh is placed deep to the abdominal wall defect. Onlay is the mesh is placed over or superficial to the abdominal wall defect. So this is the mesh here, and this is the abdominal wall defect here. And inlay, that is when the mesh is placed within the muscle of the defect, like that. And with that, we reach the end of this video. Thank you guys for watching. Please make sure to like and subscribe. And if you want to support more, you can by subscribing to the Patreon. Link provided in the description of this video. Thank you guys for watching, and peace.